Good evening. Welcome all. I, Dr. Deeptimala Agrawal, on behalf of Indian Society of Critical Care Medicine, Agra chapter, welcome you all to the second webinar, Learning Latest Trend for Opportunities series on how to manage cases. The first webinar was on stroke, and today our topic is targeting timelines in trauma patient. I welcome our chairperson, Dr. Ranveer Singh Tyagi, Director, Department of Anesthesia and Critical Care, Synergy Plus and Galaxy Hospital, Agra. And for this topic deliberation, we have Professor M.C. Misra. Sir was associated with All India Institute of Medical Sciences for 37 years before laying off office on 31st Jan 2017. While most people know him as Director of AIIMS New Delhi, but one of his greatest contribution has been towards the creation and development of AIIMS Trauma Center, one of the main point of contact to provide state-of-the-art, compassionate patient care to all acutely injured patients and those requiring specialized services. He is the man truly responsible for the establishment of Apex Trauma Center, AIIMS. Sir believes in improving the trauma care services in our country by capacity building in trained human resources. So with this, I welcome Professor M.C. Misra for the topic, Targeting Timelines in Trauma Patients.
Thank you, Dr. Deeptimala, for giving me this opportunity this evening to share some of my thoughts on trauma care in India and what we have, what we need to improve, and what we need to have. There is a huge unmet need of resources, both trained human resource as well as material resource. So this timeline, I think the topic which you have selected is very vital. As you mentioned in your opening remarks that this is the second webinar. First one was on stroke. So these timelines actually are relevant for stroke, as much relevant for trauma, and also the myocardial infarction or heart attack when we say that. I am going to share my screen. So I hope this PowerPoint is visible.
Yes, sir.
So what I actually term trauma or injury, whatever we call it, an epidemic of this current millennium. And it is incumbent upon all of us, trauma care provider, immediate care provider, critical care providers, emergency care providers, to improve emergency care in general and trauma care in particular. And as we know that we have a huge population, so I dedicate this webinar to the trauma victims in the past, present, and future. A lot of people lose their life, the limbs, the breadwinners of their family. And I consider, and many like-minded people do consider, that this is the neglected disease of modern society. What we need. Thank you, Chairperson, Dr. Ranveer Tyagi ji.
Sir, good evening. Sorry, sir, I stuck in one.
So thank you for giving me this opportunity. So as you know, the 60% of India's landmass is earthquake prone. And like in North India, Himalayan belt, the Delhi region. We saw some of the worst earthquakes in Gujarat, Maharashtra, Northeast. So basically, Delhi is on a ticking bomb. When it will hit Delhi, we don't know, but Delhi comes in a medium to high seismic zone. Then India also has the distinction of having a huge train network. And we have seen some of the worst train disasters. And besides the natural disasters which we see, and we lose a lot of lives and livelihoods, we also have a now huge road network. And that also brings, development brings its own side effects, as we say. We do come across occasionally such bizarre injuries like this young boy who was climbing a tree. It happened somewhere near Indore a couple of years ago. And then he fell on a tree and this wooden impalement happened. He was, when we say time is of essence, this boy sustained this injury 2 o'clock in the afternoon, and he could receive the definitive care around 10 p.m. He reached to a definitive care hospital. So that is the kind of scenario we are living in. Now, this is again a young boy who was traveling in a taxi, hit a metro construction site, and this angle iron impaled him in the seat. He was fully conscious. He calls his mother that this has happened. This happened 6:30 in the morning, and I may not survive. That's what he said. And so the pre-hospital providers brought him to trauma center, and he walked home. Now, if we say timelines for trauma, they must begin with the pre-hospital evacuation after some basic life support, if that is indicated. For example, if there is external bleeding, I think the pre-hospital rescuers should be able to put pressure on that bleeding, should be able to open the airway, if not nothing else. And then they are brought to the emergency department of a hospital, which may be equipped to deal with such situations or may not be. But if the doctors and nurses are trained in initial assessment and management of life threats, then many of the lives can be saved. And following initial assessment in emergency department, patient either within the same hospital goes to operation theater, depending on the physiology of the patient, or patient goes to critical care unit, or to ward, or maybe discharged if it is a low injury severity patient. Now, when we look at the economic cost of trauma care globally, annually it costs $500 billion, whether we want it or we do not want it. So it consumes a lot of resources from societies. And many accidents, although we call them accidents, but they are really not accidents, they can be prevented. And if we compare injury versus cardiovascular diseases, which are the commonest reason for disability adjusted life year lost or cancer, it exceed because of injury, because injury is the disease of the young. And there is a high mortality in the so-called golden hour. And in India, many of these patients, or I would say large number of patients, at least coming from remote areas, do not reach within that so-called golden hour. So it is a major public health problem globally, and it does affect most productive years of any nation. Now, if you compare what WHO had predicted in 1999, and this is, if you one compares what WHO projected in 2004, and now what is the situation in 2023, the daily deaths, 13 every minute, 18% of the global burden of the disease, 20 to 50 million significant injuries, the dailies, the disability adjusted life year lost, and trauma is the third leading contributor to global burden of the disease. Just to give you a sense of it, in 1990, these were on left side were the diseases which were responsible for these loss of dailies. An injury was at number 9 position. But when we see in 2020 and beyond, now we are in 2023, almost midway, the injury has moved to number 3 position only after cardiovascular diseases and mental health illnesses. Now, if we look at the trauma, why it is a public health problem, and because of the reasons which I have already cited, and it is also given somewhat here. And if we look at road traffic deaths alone in India, we see that from 2005 to 2011, there has been almost 7.5% to 9% rise in road deaths, barring one single year, that was 2008 for some reason. And after 2011, if we see, there was a decline, and we thought that maybe injury prevention strategies are working. In 12, we saw 1.6% rise. 13, we saw actually minus 1.2%. And 14, again, it rose to 3. And in 15, it was 5%. So the annual rise in accidental deaths or road deaths is still very significant and worrisome. Now, when we compare two large democracies, that is India and USA, the total population of India is, all we know, it is almost 4 times that of USA. Number of vehicles in India are far less, as you can compare. Road accidents also are far less in India. Over 400,000 accidents happening. But total road fatalities, if we see, and that is an old figure given on this comparison, it is almost 2.5 times of that USA. And total road injuries compared to number of accidents are almost 1:1 ratio or even more. In India, in USA, the number of injured are almost 2.9 million. Now, if you look at the ratio between the injured and dead, we have a very fair chance of dying in a road crash on our roads. That is 1 in 5 as opposed to 1 in 69. And that speaks about the whole trauma system is not geared. It is not developed in our country as opposed to developed countries like North America. Now, so the mortality in injury severity score of more than 16 in our country, I have seen at trauma center, it hovers around 10% beyond 24 hours, or as opposed to US, because it's a developed society, about 4%. 90% of road traffic deaths are happening in middle and low income countries like India and other Asian countries. So we lose almost 3% of our GDP because of road traffic injuries alone, whether we like it or not, whether we want it or not. So if we look at all trauma is not road traffic injuries, but in India, the proportion is very high. Like I said, 40%, almost 38%. The other types of injuries are almost 70%. And when we say road injuries, 72% of motorized automobiles on our roads are two-wheelers. They are not four-wheelers. So these are the reasons. And behind each death, there are 12 to 20 times or even more severely injured patients. And even more number with minor injuries, so-called minor injuries, which also give a lot of morbidity and long-term disability. So very high mortality and morbidity amongst those with multi-system injuries, because we do not have a very rapid pre-hospital rescue and evacuation. And then even if that happens, the hospital emergency departments may not be geared to cater for such severe patients with severe injuries. And so there is a paucity of acute trauma care or emergency care for that matter, even emergency care for that matter. So we do need some broad policy framework to develop some kind of a trauma system which to improve this lot. In US, it was realized in way back in 1966, where they published this report, white paper called Accidental Death and Disability. And they took some measures and developed the trauma system, although it costs. And now India is in a better economy, and we can actually think about that for future. Now, protocols in initial trauma management, the beginning was by an orthopedic surgeon called James Steiner. He was traveling in his own plane with his family in rural Nebraska, USA. That plane crashed. His wife died in that crash. He himself and his 3 children were severely injured. And when they were taken to a nearby facility, after he recovered from his illness, he shared his experience with his colleagues that there is something wrong with the system and system needs to be changed. So he, along with his colleagues in American College of Surgeons, prepared the first prototype of ATLS on the lines of cardiac life support courses and made that first course in 1979. Now, another emergency care provider, Peter Safer, changed the whole concept. Like in elective clinical care, we start with the history, examination, diagnosis, investigation, etc., etc. But then he said, in emergency care, that will take time and we may miss out on, like you are saying, that time is of essence. So we do a quick primary survey looking at ABCs, because A kills before B, B kills before C. And simultaneous resuscitation go hand in hand according to priority. When patient has been stabilized, then only we take relevant brief history other than mechanism of injury. Only when patient has been stabilized, we go for a detailed secondary survey, head-to-toe evaluation, and resuscitation continues if that is required from ED to OR or ED to critical care or OR to critical care. And then we treat the underlying injury. So that is how the life support, there is a basic life support, which I think all pre-hospital care providers must be trained in. Advanced life support, now we have in India also, there are certain ambulances which are advanced life support. BLS, basic life support, can be without adjuncts. BLS can be with adjuncts. But that will depend on the level of training of these paramedics on the ambulance. And then the advanced life support like cardiac, pediatric, neonatal, and trauma. Now, trauma also has a tri-modal death distribution. what I'm trying to convey here, that there is an immediate peak. 50% of those who die before they are brought into the hospital. Now, this peak can only be impacted by injury prevention strategies like helmet enforcement, seatbelt enforcement, speed limits, drunken driving, and drivers, like in commercial vehicles, drivers drive continuously for 18 hours and fall asleep. And deprivation of sleep is one of the important reasons for road accidents. Now, so this can only be impacted by injury prevention strategies, while the second peak, which is early deaths, can be prevented or minimized by efficient emergency care in the emergency department. Now, basically in USA, sorry, this peak has little bit swelled, the early deaths, because of the efficient pre-hospital rescue. And the third peak has plateaued. There is a third peak, which is late deaths, which happen in our critical care units after several weeks of injury. If they are not taken care of well here, then the patients die in critical care units several weeks later after having made humongous efforts by all critical care specialists. So what our objective should be, if we take care of these patients well in the so-called golden hour, and for India, I also say many of these patients, since they do not reach us within that golden hour, they reach us after several hours, 4 hours, 8 hours, 24 hours, several days. Let's convert the first hour whenever they reach us as the golden hour. And many of these patients with severest of injuries can be salvaged, returned functional and productive to society. And this peak then can come down. Now, trauma system naturally has a very strong component of pre-hospital care, rescue, evacuation, in-hospital team, and also critical care unit. So a chain of survival actually starts in the pre-hospital setting. It is said anybody who touches the patient first determines the outcome of that patient. So early access to care for a trauma patient, early resuscitation, transport to appropriate facility. There is no point in taking to a closest healthcare facility if the resources are not there. So, and the pre-hospital providers, pre-hospital rescuers must be aware of that. Also, the doctors who are manning our primary healthcare facilities, community healthcare facilities, small nursing homes, they must be aware, fully aware what resources they have and to what extent they can treat that particular patient. And if they think based on the physiology of the patient and subsequently anatomic injuries of the patient, if the resources fall short, then these patients need to be referred and transferred to it for definitive care to the closest appropriate facility, healthcare facility. And if that decision has been made after stabilization of the patient, then that must be implemented as soon as possible and without wasting time to do a lot of investigation, because that takes time and unnecessary if we are not going to manage that patient at our own facility. And so the early referral for definitive care is the key to success, either within the same hospital or inter-hospital referral and transfer. So that is something we all must be aware. So trauma team it is the same physicians, emergency care physicians, critical care specialists, anesthesiologists, trauma surgeon can make a good team anywhere because most hospitals have these people. So it should be organized, it should be cohesive, and people must be properly trained so that everyone speaks the same language and there is no confusion. So that is where we need local leadership in every healthcare facility. So common language is the key. Nurses, the physicians, the paramedics, everyone speaks the same language. And that is something we emphasize in advanced trauma life support courses, which we conduct. Currently, in India, we have 29 sites. We have conducted so far 700 of these courses since its inception in 2009. And it is all voluntary participation. So people are, our doctors are willing to come forward and learn and improve care in our country. And that's a very encouraging scenario, which I can vouch for. Now, initial assessment. So that was the component where I wanted to highlight the problem for India and in global perspective. So initial assessment and management of a trauma patient that is in hospital acute care is the key when patient has been brought alive. And I must say, recently I was in Indore in your Indian Society of Critical Care Medicine meeting, and Dr. Rajesh Misra, who was the president, actually commented that if a patient following trauma is brought to my ICU, and if patient dies, there is something wrong with my ICU, and I would not let that happen. It was a big statement, but very responsible statement, and that is quite to some extent, I would agree with him. So this is what we do in ATLS these days. It's an interactive discussion, which is scenario based, and we use a MIST acronym, where M stands for mechanism of injury, which is often forgotten by our young doctors to ask the patient or the relatives how this happened, because many injuries and one can suspect on the basis of mechanism, whether it's blunt, whether it's penetrating, whether it's a fall from great height, so that the benefit of doubt goes to the patient and not to the doctor. I stands for injury sustained, S stands for vital signs, and any treatment received before patient was brought to emergency department. So here is a case scenario, 44-year-old male driver crashed head on into a wall. He was unresponsive. So naturally, this gives some clue that this patient might have sustained either head injury, or he must be bleeding and in shock. That's why he's unresponsive. And he arrives at hospital with basic life support, with the oxygen, with the cervical collar in place, spine board, and technicians assisting ventilation with bag mask. So that is the sequence of priority in such a patient would be ABC, assessing the airway with C-spine restriction and also breathing along with ventilation. So I'll come to that. So the objectives of initial assessment is basically for all of us to understand principles of primary and secondary assessments. And this is a unique terminology we use in ATLS. Also, there is a certain algorithm which we use when we manage these patients according to priorities. And priorities remain the same. A kills before B, B kills before C. So we need to take care of airway first, and then breathing and ventilation, and then go for circulation, which means stop the bleeding. And then perform appropriate resuscitation and attach monitoring procedures in these patients. Stabilization and resuscitation go hand in hand, and also recognize that the value of patient history and biomechanics, because it is so important. Now, for every doctor and nurse in emergency department, it is highly recommended, and we all have gone through COVID over last 3 years, to take universal precautions for your own safety. Put on a cap, gown, gloves, mask, shoe covers, whatever, so that you do not come in contact with body fluids and blood directly. Now, initial assessment and management, basically rapid and accurate assessment of patient's physiology, because deranged physiology would kill first before anatomic injuries would kill. Anatomic injuries per se will not kill in a prioritized manner, and which is basically resuscitation and stabilization of these patients. So priorities, rapid primary survey. What it means basically, assessing the airway. If the airway is okay. Simultaneous resuscitation of vital functions. So if we are in a tertiary care setup, we may have more than one person. So somebody is looking at airway, somebody is looking at breathing, somebody is looking at circulation by putting in IV lines. So one can have a team. But if we are alone, if I am alone somewhere, then also the priorities will remain the same. It will be kind of a vertical resuscitation rather than a horizontal resuscitation. So only when patients' vital functions are returning to normal, we go for detailed secondary survey. Reevaluation is the key to success in managing trauma patient. And then, as I already mentioned, transfer to definitive care, either within the same healthcare facility or closest appropriate facility. So how do we assess? In a quick, simple way to ask patients in 10 seconds, very simple. If the patient is conscious, telling his or her name, and also telling you how it happened, what does it convey? Very quickly, it conveys patent airway. We all know that. We also know that patient has sufficient air reserve for speech. And also, since he or she can remember what happened, there is a perfusion to brain. So ABCs can be assessed very quickly and clear sensorium, that is full GCS. And if some patient is not doing that, that person or patient requires immediate attention, because that means the airway is not okay, or patient may be having head injury, patient may be in hemorrhagic shock, because in trauma, if there are compromised vitals, the first and foremost reason for it, the hemorrhage. So we must look for that and anticipate in such situations. So primary assessment is basically airway with C-spine restriction. Now we say breathing alone is not sufficient. Shallow breathing along with that ventilation must be happening. The oxygen exchange, the oxygen saturation. Circulation means hemorrhage control. If it is external bleeding, needs pressure. If it is internal bleeding, may need emergency laparotomy or thoracotomy, depending on the bleeding is happening in the pelvis or in the abdomen or in the chest, and only when ABCs. So for resuscitation, we may have to take the patient to OR at times, occasionally. Only when ABCs have been taken care, and then we say primary survey has been completed. Only when patient has been stabilized, we go for disability assessment. And in trauma, context of trauma, disability assessment is nothing but neurological assessment, the brain injury, the spine injury, and not orthopedic disability. When ABCDs have been taken care, we expose the patient. Also conscious of the temperature, body temperature, because many of these patients, when they are given fast crystalloids and blood products, can slip into hypothermia, coagulopathy, acidosis. We must prevent that and preempt that. So it is always recommended when we say circulation, it is the Ringer's lactate, the basically crystalloid, or whatever fluid is available. And we generally now recommend that not more than 1 liter of crystalloid. If patient needs further fluids, then blood products must be arranged as quickly as possible. and started in these patients to avoid these patients slipping into hypothermia, and also pre-warmed crystalloids and blood products. That is desirable to avoid hypothermia, coagulopathy, and acidosis, the triangle of death in trauma. Now, priorities remain same for all patients in all scenarios, whether it's a child, whether it's an elderly patient, whether it's a woman with pregnancy, it remains the young patients, priorities will remain the same, and the priorities are A, B, C, D. So if we remember that and remind ourselves again and again, we will have better outcomes of our patients. The purpose of primary assessment or primary survey is identification of immediate life threats requiring, and when we say primary survey, we say if there is an immediate life threat, suppose somebody has a tension pneumothorax, somebody has a cardiac tamponade, somebody has an airway obstruction, then let's secure the airway first, then move on to assessing the breathing. So that is the sequence we follow in identify the immediate life threats. Only after this, we proceed for secondary survey. So overall, secondary survey is basically after ABCs have been taken care, patient has been stabilized in terms of physiology. We do overall body examination, head to toe, front and back. We may have to log roll the patient to look for any bleeding on the back, and the vital signs must be returning to normal. Airway with C-spine restriction is key, and breathing basically after airway has been taken care, we look, listen and feel for other injuries to the airway, to the chest, to other systems of the body. Now, if the airway is patent, patient is speaking, his vitals are okay, then that's fine. But as soon as we know that Glasgow Coma score is less, compromised vitals, so airway threatened immediately because of head trauma, because of the bleeding. And that is something we have to anticipate, preempt, and take care of this. Basically, intubate such a patient. May not require ventilation immediately, but at least in a head injured patient, as soon as patient GCS is less than 8 or less, the airway is threatened because the tongue falls back. And it is also said that most patients with head injury in pre-hospital setting die of airway obstruction rather than head injury per se, because as soon as patient is unconscious, the tongue falls back and airway is obstructed. So maintaining airway is, we may have to just open the airway in the pre-hospital setting, clear the airway of any foreign body secretions, and use the devices which may be available on the ambulance. But all trauma patients must receive supplemental oxygen, high flow supplemental oxygen in pre-hospital setting. If there is the ambulance, it is available, or at least as soon as these patients arrive in our emergency department. And those where the GCS is 8 or less, definitive airway, that is orotracheal intubation. Now, surgical airway is only when there is a facial-maxillary injury, it is difficult to put in an endotracheal tube, then one can use either needle cricothyroidotomy or surgical cricothyroidotomy. Now, breathing and ventilation comes next after airway has been taken care, and one can assess by looking at the respiration, the neck veins, chest movements, and any sign of injury or decline in mental state. Listen carefully, chest. Also feel for any dullness, hyperresonance, which may suggest pneumothorax, subcutaneous emphysema, and any deformity. So, as I already mentioned, the oxygen saturation has to be looked at. And in primary survey, at times we do arterial blood gases as an adjunct. Also, I'll come to what adjuncts we can do. Limited adjuncts are needed during the primary survey. Ventilation with bag and mask device, if endotracheal intubation is not possible, tension pneumothorax is present, needle thoracostomy, and nowadays even finger thoracostomy is recommended. So in open pneumothorax, it's a standard recommendation. I think most physicians know for 3 sides cover, so that and if at all, chest tube has to be put in from a different area. In 5th intercostal space, anterior to mid-axillary line, that is the preferred site for endotracheal or this intercostal chest tube drainage. Now, ventilation is only when there is apnea or hypoventilation, flail chest, diaphragmatic injury, spinal cord injury, GCS less than 9, or there is hypoxia and hypercapnia and hypothermia. Now, when we say hemorrhage, hemorrhage is the major killer in trauma. So what we must remember, 1 on floor, 4 more. 1 on floor is the external bleeding, while other cavities which may harbor liters of blood would be chest, abdomen, pelvis, retroperitoneum, and also muscle compartment of long bones like in thighs. So put together, if there are multiple injuries, blood loss actually can be very severe. So circulation means basically stop the bleeding. So we must assess all the vital signs and all the basic teaching what we have, capillary refill, blood pressure, etc. Now, direct pressure will control most of the external bleeding most of the times, except in combat zone, when we have our armed forces on the border or our security forces, when they sustain blast injuries, they sustain high velocity gun injuries, then it becomes difficult. That pressure only alone will stop that bleeding, and we need to use basically tourniquet in those settings, and also very aggressive fluid resuscitation, blood and blood products, and one may have to give even non-cross-match blood, group specific, and because nowadays to avoid coagulopathy, we actually give the blood earlier, and also along with the blood, we also consider if there's a massive transfusion, the massive transfusion protocol has to be put in place. That is, for every PRVC, we give the platelet and FFP 1:1:1 ratio for massive transfusion, and also be conscious to prevent hypothermia. I think that is something we must not lose sight. Only when ABCs have been taken care, we assess a detailed Glasgow Coma score, which has 3 components, as I think most of you are aware: eye-opening, verbal response, and motor response. And then depending on that, we suspect whether this GCS is low because of head injury or because of the hemorrhage. Now, exposure is crucial. If you take literature, the missed injury rates have been up to 50–60%. They might be minor, but they also give morbidity. So we need to examine this patient completely after resuscitation and stabilization. So what we say, there is a primary survey, quick. There is a secondary survey, detailed, imaging, etc., whatever are indicated, and also protection from hypothermia, and we must examine both front and back not to miss any injury. During the primary survey, very limited adjuncts are done, like 2 X-rays, chest and pelvis. They are done not to diagnose chest injury or pelvic, to look for bleeding in case patient is not responding to resuscitation. So bleeding can take place in the chest. There may be pneumothorax. There could be bleeding in the pelvis. Actually, pelvic bleed can lead to death even in 2023. 2 tubes, orogastric tube and urinary catheter, provided we avoid putting in nasogastric tube in head injury patients. Urinary catheter, ensuring prior to putting in urinary catheter, there is no blood at the meatus. And now we also have added EFAST, the extended focused assessment by sonography in trauma, where we have in abdomen, the left hypochondrium, right hypochondrium, the pericardial window from epigastrium, and also the pelvis, if there is any free fluid in the pelvis. So what FAST can tell you the free fluid. Now, that is why less and less now diagnostic peritoneal lavage is done, because diagnostic peritoneal lavage is also not done because most of the patients with solid organ injuries like liver and spleen are managed non-operatively. We also emphasize that no unstable patient who is hemodynamically unstable patient goes to radiology department or where X-ray. Radiology must come to the patient. FAST is done on bedside. So are the plain chest X-ray and pelvis X-ray can be done on the bedside. I have mentioned about transfer. I'll again repeat. If there is a healthcare facility, do not have resources for that particular patient, this patient must be, if a decision has been taken, that patient must go to an appropriate healthcare facility for optimal management. And generally, I give an example of head injury, because neurosurgeons are not there everywhere. There may not be CT scan facilities. So if patient has head injury, you do not have neurosurgeon, CT scan facility, then these patients need to be transferred to the closest appropriate healthcare facility where they can be taken care. And what we also emphasize, whatever time is available to us before transfer must be used for resuscitation rather than doing various diagnostic tests if we are not going to manage this patient in our facility. Only when patient has been stabilized, we take a brief and relevant history, detailed anatomical examination, head to toe, front and back. And as I was mentioning, there is a quick primary survey, there is a secondary survey, and we also call particularly in a mass casualty incident, and it will work for an individual patient also, to before discharging, go through a tertiary survey, so that we do not miss any injury. Now one can take a little bit of history of any allergy, any medications patient might be on, like in elderly patients are on multiple medications, beta blockers, blood thinners like antiplatelet medication, and any past history, pregnancy in a child, women of childbearing age, last meal, because many of these patients may be taken up for general anesthesia, and events that led to sustaining these injuries. So mechanism of injury is extremely important, and it should be upfront known, whether it's a blunt, it's a penetrating, combined, blast, thermal, heat or cold. All this will determine how we take care of these patients and what could be the problems we can anticipate and preempt those problems. And then do a detailed head to toe, front and back examination, starting from head and neck, maxillofacial, chest, abdomen, pelvis, extremities, and back with per rectal examination or per vaginal examination, depending on the patient. Detailed neurological examination only after ABCs have been taken care, and GCS, pupils, lateralizing signs, spine assessment are important. And when we are doing log roll, we must see that the spine does not move that much so that we do not inflict any secondary damage. This is what I mentioned, re-evaluation and tertiary survey for less severe injuries, unrecognized injuries during the primary survey and secondary survey, and also underlying medical problems. Having a high index of suspicion for particular injuries based on the mechanism, history of fall, for example, from a great height, or involved in a high-speed crash. Adjuncts to secondary survey. During secondary survey, we have all the time at our disposal. Patient is stable. Do CT scans. Body CT is these days very common. We do when we take the patient with polytrauma. We do a head CT. We do a chest and a torso CT, and require, depending on the spine, C-spine, etc., and any X-rays which are required, contrast studies, angiograms in a stable patient. So no unstable patient or suspected to be going into hemodynamic instability should be taken to radiology. Once patient has been stabilized, then it's also incumbent upon all of us to put a medical legal documentation, because most trauma patients, we have to have medical legal aspect also covered, and it should be in the order the patient came and whatever procedures, consent, etc. has been taken. So summarizing initial assessment and management, basically a quick primary survey in the priorities A, B, C, D, E. Resuscitation and stabilization go hand in hand. Very limited adjuncts during the primary survey. Those are attaching the monitors, ECG, saturation, ABG, orogastric tube, urinary catheter, X-rays, fast, etc. Re-evaluation is the key in trauma because it's a dynamic disease. Trauma is a dynamic disease. It's unlike many elective problems, health problems. So situation may change. Patient might be stable 10 minutes earlier, may become unstable because bleeding has started. We tried to resuscitate and blood pressure went up and bleeding started. So all this can happen in trauma. Only when patient has been stabilized, we go for a detailed secondary survey, do whatever adjuncts are indicated in that particular patient, because all patients will not need all the investigations. But the re-evaluation goes on until patient has been transferred for definitive care under neurosurgeons, under orthopedic surgeons, or trauma surgeons to ICU, to OR. I think that is something we must all remember. So transfer to definitive care in the same healthcare facility or in the closest appropriate facility is the key to success in injury. So success is something we learn from our failures in the past. And if we can train ourselves, if we can make ourselves aware, then I think most people we can improve outcomes, and also it will be much more satisfying. Thank you so much, Dr. Deeptimala, Dr. Tyagi, for giving me this opportunity. So I'll be happy to take if there are any questions.
Thank you very much, sir, for giving time on giving a lecture, also on excellent talk on trauma.
I lost your
Dr.
voice.
Ranveer, we cannot hear you.
We lost his voice.
Yes. Dr. Ranveer?
Yes,
Yes, yes, please.
hear me?
Yeah, now we can hear you. Yes.
Okay. So
Please.
question, sir. Some question is how the principle of damage control resuscitation in emergency room.
That's
How
a
to
very,
apply the principle of damage control resuscitation in the emergency room.
again, I just spoke to during a CME on this Sunday itself on damage control surgery, damage control resuscitation.
Ji.
Again, what basically damage control resuscitation means to, and also procedures, we do minimum which will stabilize the patient. For example, because damage control, I can give you one example. Say a J&K police personnel was shot with the AK-47 automatic rifle and with a very close range. So he was taken to the command hospital of Northern Command in Udhampur, and he was resuscitated for whatever, but he was in severe hypotension. So he was taken to operation theater. He underwent 3 laparotomies, 1 thoracotomy within 24 hours, and 30 units of blood was given to him. And then they could not control the bleeding from liver because liver was severely injured. And they put in a lot of packed the packs, basically what we have sponges to control that bleeding. And we then airlifted him to Delhi, where after 72 hours, after normalizing the coagulopathy, any feature of DIC, correcting the hypothermia, we took him to OR for removing the packs. And then also while packs were in, abdominal packs were in, we also did a hepatic artery angiogram and embolized the hepatic artery. So damage control resuscitation is basically doing minimum to stabilize the patient. And now in bleeding, hemorrhage is the main killer in trauma. So getting blood and blood products, instituting massive transfusion protocols, and that is all comes in basically damage control resuscitation and then damage control surgery, where we do minimum, and it's a well thought of strategy. It's not an afterthought that we decide that we are going to do minimal. Basically, in surgery, when we say damage control, what we say that controlling the hemorrhage, controlling or preventing the contamination is the key for success in damage control surgery, and then take the patient for definitive repair or definitive surgery at an appropriate time. And these patients actually are taken to operation theater from, and this damage control resuscitation from operation theater is taken to ICU. Basically, these patients, such patients, they require this resuscitation where we deal with acidosis quickly so that they do not land up with severe acidosis, coagulopathy, and also hypothermia, because hypothermia is very crucial because they are all interrelated and the mortality is really high if the patient is in severe acidosis. So I think the damage control resuscitation is preventing these components which will lead, increase the chances of decrease the chances of patient survival.
Thank you, sir. One more question, sir. Dr. Abneesh Bharadwaj, sir, from Jaipur. He is asking importance of proper training in ATLS for better outcome after trauma is undisputed. The cost of ATLS training is more and is avoided constant for the universal training. To encourage involvement of medical men opting ATLS training, is it not fair to develop equally sound and robust Indian trauma life support? training because ATLS is costly. So please share your view on that.
Avnish ji, first of all, I don't agree with you that it is expensive. The other thing is there are number of courses. There is something called ITLS. There is something called CTLS, Comprehensive Trauma Life Support Course, International Trauma Life Support Course, and some you can devise your own courses. There is nobody stops because ATLS is only one. It's safe way. What we say, we don't say that this is the only way you can manage trauma patients. These days, the students must spend some money on their skill development. If the students cannot pay, and I don't think that most residents cannot pay today, whether in government or private, then the universities and the institutions, wherever they are working, they should subsidize these courses. Ultimately, you realize that any good course will need a lot of personnel, the faculty, the setup, the time, and travel. So the cost is not for anything but to cover these costs. If these costs are subsidized by the institution, university, and once you see in India, you are talking that if somebody is charging 20,000 rupees, it's an expensive course. You know how much these students before joining training program in developed countries, they have to pay and do these courses before they go for training. They will not be allowed to start their training before going through these courses. So I think cost is a relative matter where if those who cannot pay, the institution should subsidize that. Otherwise, if they can pay to you to join MD program, MS program, paying 20 lakhs, 30 lakhs, why we should say that it's an expensive course? In government, they get very good salaries these days. All junior residents, all senior residents are very well paid. So I think we are no longer a poor country. I would accept that. And I think most students, see, we have trained almost more than 10,000 doctors and dental surgeons. And most of them have come voluntarily, spending their money. If some of them got reimbursement from their institutions. So I think it is how much importance you attach to these trainings. I think it all boils down to that. People go and spend in shopping without even thinking once or twice. So I think that is something is a relative, I would say. It's not something definite. I agree that those who say that they cannot pay, somebody should support them.
Thank you, sir. Thank you very much, sir. I think we are completed 1 hour exactly. So some people are leaving. So thank you once again, and thank you very much, audience, for giving your time to listen. And thank you, Misra sir, for your excellent talk on this trauma, timely management of trauma. Thank you, sir.
Thank you, Dr. Deeptimala. Thank you, Indian Society of Critical Care Medicine and Agra branch and Dr. Tyagi for giving me this opportunity and to sharing some of my thoughts. And thank you, Dr. Avnish, for asking that question. You may not be very happy with my answer, but that's okay.
Thank you, sir. Is my teacher. My regards to Avnish Bharadwaj, sir. Sir, my teacher.
Avnish ji is the head of anesthesia now at Mahatma Gandhi.
Sir, I'm doing my PG from SMS. Sir is teacher that time. My teacher in SMS.
वहाँ पे थे आपके साथ, teacher थे.
Yes, sir. Yes, sir. Thank you.
धन्यवाद, Avnish ji, for asking that question. My reply remains the same whenever somebody brings the cost of this ATLS.
Thank you, sir.
It has been an honor and pleasure to have you, sir.
Thank you, Mala. Thank you.
Thank you.
Thank you.